And now it is my pleasure and honor to have Professor Wilfried Myllens, a dear friend and colleague. Actually, we trained together at Cleveland Clinic in 2006-2007. He's the head heart failure section and cardiac rehab at Ziekenhuis Oost-Limburg. I don't know if I pronounce it right, Genk, Belgium. He's professor of cardiology and professor at School Medicine and Life Science of the University of Hasselt, Belgium. He's a board member of the Heart Failure Association, and he is leading several study groups, especially the cardiorenal. His research is based on acute heart failure, the interaction between the kidney, the heart and the kidney, and the decongestive and diuretic strategies in acute heart failure. Wilfried will present to us today about the management of acute heart failure, basically the decongestive strategy, because it's the most important. As Dr. Firas has said, congestion is the mainstay of acute heart failure decompensation. Wilfried, the floor is yours.
Thank you, Hadi, for the introduction, which is way too long, and I welcome everybody in Lebanon to this exciting webinar. Trying to progress my slides. So these are my disclosures. I'm a heart failure specialist, just like Hadi and Firas, and I think we all would like to have a physiological approach to understand what we're doing and also to know what we need to be doing to help our patients. And I'll try to explain in the next 25 minutes how I think you can improve the use of diuretics and why you should understand the pivotal role of the kidney in heart failure. This is my first disclosure. My second disclosure is that my wife and I, we fell in love with Lebanon. We fell in love with its people, not only Hadi, but so many people in Lebanon, which became friends over the years, and also, of course, your food. And we try to visit Lebanon at least once a year to see a lot of really, really nice places. And then my third disclosure is that Hadi Skuri is one of my best friends. Like Hadi said, we trained together in the Cleveland Clinic it's almost 15 years ago now, and we remained friends over the years. I'm very happy that Hadi just became a father 2 weeks ago. You might know that, but now he's a daddy again. Anyway, so I think we have to understand with regards to heart failure that we underappreciate the risk that our patients having to die or to be hospitalized. This is from the Paradigm trial. So that means that 1 out of 5 patients that you see in your daily office is either dead or hospitalized with heart failure after 2 years, because this was a study in ambulatory patients. The same is true of the SGLT2 studies. SGLT2 studies in ambulatory heart failure, almost 1 out of 5, 1 out of 4 of those patients are either dead or hospitalized after 2 years of follow-up. So that's a very bad prognosis. It's even worse once your patient is actually hospitalized. Once he is hospitalized, that risk goes up to 60% at 1 year, especially if you don't do your job well. If you send your patient home with ongoing congestion, the risk for that patient to be re-hospitalized is extremely high. And that is why we have to understand what we have to be doing. We have to understand how the kidney works. The kidney is a remarkably vascular organ. It gets 1 liter of blood every minute. That means 600 cc's of renal plasma flow every minute. Like Dr. Firas was alluding to, we realized over the last 15 years that it's not so much cardiac output which is driving the problem in the kidney, but more an increase in central venous pressure. This was a study what Hadi and I did in 2009, where we specifically looked at patients who came in with a low cardiac index. All of these patients had a cardiac index below 2, cardiac output below 3 liters per minute. And the only prognosticator to say if the patient was going to do bad with regards to kidney function was the increased central venous pressure. The higher the central venous pressure, the more worsening renal function we were seeing during the hospitalization of heart failure. That is why we put a lot of time and efforts in research to understand how this is driving. One of the experiments was a rat experiment where we did a selective ligation of the vena cava inferior. So we didn't change the heart, we just changed the venous pressure in the kidney. And you could see already after a couple of weeks that there were irreversible changes on the glomerular level in kidneys who have been prone to elevated central venous pressure. That's also one of the reasons, like Dr. Firas alluded to, that we're aiming now to image better the kidney. And instead of putting your echo probe on the heart, I would encourage you to put it on the kidney. And then don't look at the line, at the signals above the horizontal line, but look below the horizontal line, and that is the renal venous flow. And normally you have a continuous venous flow. That means that there's continuous flow of blood out of the kidney. If you have heart failure, even before the onset of overt congestion, you sometimes see discontinuous venous flow. And as soon as you see that, that is the moment that your diuretic therapy is less effective. So by just looking at the kidney, assessing venous flow, which takes you like say 20 seconds, you already can have an indication if you have to change your diuretic dosing if there is discontinuous venous flow. And the core of the problem, of course, is that we eat too much sodium. Most of the sodium that we're eating, over 70%, is in prepared foods, because sodium is normally something that you don't really like. If you have to eat a tablespoon of sodium, that it will be tasted as disgustful. But if you put it in prepared food, we really like it. What we don't realize, or what probably most of you don't realize, is that all of that sodium that you're going to eat is reabsorbed in your gut. And that is because we have a very intense RAS activity. So all the sodium that you're eating will be absorbed in your gut. And it will be very difficult for your kidney to get rid of that sodium. If I would eat every day a bag of potato chips for the next week, yes, I would excrete more sodium. However, I would still have a positive sodium balance. That means that after 1 week, I will have more sodium in my body than currently. And that is, of course, exaggerated if you have heart failure. So then you can ask the question, if I have more sodium, if I eat 1 week every day a bag of potato chips, where is the sodium then? It's not in my plasma. It's because we have reservoirs. Most of us, everybody has reservoirs where we can store sodium in a fashion where it's not going to do harm. And most of that stores are in the bone, but also in the skin. This is one of my PhD fellows doing a skin biopsy in myself to look if I was storing sodium, and yes, I do. And heart failure patients have a disruption of that sodium stored in their skin, and therefore those heart failure patients will have more sodium also in their plasma. If you have more sodium in your plasma, you will filter it in your kidney. And a normal kidney filters about 1 kilogram of sodium every day. 1 kilogram, that's really a lot. We eat about 4 to 5 grams of sodium. So 1 kilogram of sodium will be filtered every day. You might think, if I have a poor GFR, I'm not going to filter enough sodium to get it excreted, but that's not correct. Because even if you have a GFR of 10 mLs per minute, you're still going to filter 150 grams sodium per day. So it means that the filter is not the problem, but it's the reabsorption. And we reabsorb most of the sodium that we filter. That is the reason why we have very long tubules. We have very long tubules to filter a lot, but then we can reabsorb most of it and we can leave the toxic substances in the urine. You have to take into consideration, though, that you normally absorb about 60 to 70% of the filtered sodium in the proximal parts of the kidney. The rest will be reabsorbed more distal. If you have heart failure, for many reasons, which I explain in this review, but I'm not going to explain it now because it would take me too much time. But if you have heart failure, the part that you're going to absorb in the proximal parts, it's not 60%, but it's up to 80%. So every bit that sodium that you filter, most of it will be reabsorbed in the proximal parts of the kidney. And that is important because diuretics work in the distal parts of the kidney. Loop diuretics work at the level of the loop of Henle, and that's distal from the side where you're going to absorb most of the sodium. So they come too late in the to be effective as really good diuretics. So if you eat more sodium, you're going to retain more sodium. If your buffer capacity is not working anymore, eventually you will have an increase in plasma volume, and eventually you will come in with congestion. And what to do then? How are we going to treat patients with congestion and volume overload? And like Dr. Faraz was alluding to, congestion is a hemodynamic pressure increase. Volume overload is edema. Congestion does not always equal volume overload. Like Hadi was explaining, you can have acute heart failure by hypertension without a lot of volume overload, but still congestion. But most of our patients present with congestion and volume overload. What we then do is give loop diuretic therapy. Loop diuretics have been tested in only one prospective randomized double-blind trial, which was the DOSE trial. DOSE trial compared a low-dose loop diuretic versus a high dose in a continuous versus bolus fashion. So 4 different treatment strategies. What you could see in this graph was that almost 50% of the patients that were included in the dose were actually readmitted or dead after 2 months. So half of the population included was back in the hospital or had passed away after 2 months, meaning that this was a very sick patient population. But what was even worse was that the freedom from congestion assessed by the physician at the end of the treatment period was only 15%. So the patients included in those were not dry when they were sent home, even though they got 4 different treatment strategies of diuretic therapy. And there it comes to the point that most of the heart failure patients, if not all, are diuretic resistant. If you would infuse yourself with 40 milligrams of furosemide, you should be out 3 liters of volume. Almost none of your heart failure patients actually do that if you give them 40 milligrams of furosemide. And there are many reasons for that. That is why HFA put together this position paper. And I'm really glad that it's one of the most cited papers of the last 2 years for European Journal of Heart Failure, because it's a very practical document where we actually explain how we feel you should be using diuretic therapy. So let me show you the flow chart, because it's not that difficult. You have a patient with congestion and volume overload. The first thing you do in the emergency room, you're not going to wait, is this patient already on a loop diuretic, yes or no? If he's not on a loop diuretic, you give him 40 milligrams of furosemide IV bolus. 40 milligrams of furosemide equals to 1 milligram of bumetanide. If that patient was not loop diuretic naive and he was already taking a loop diuretic, you double the dose. So if he was on 40 milligrams, you give him 80 milligrams IV bolus as soon as you see that patient. You don't start a drip, or you may start a drip, but if you give a drip, you have to first give a bolus to reach the target level in the kidney, and then you start your continuous infusion. But the bolus is far easier. You give it as soon as you see that patient. And then very importantly, you have to evaluate the effect of the loop diuretic. If you see a patient with a STEMI, you place a stent and you look at if there's flow in the blood vessel. The same is true for diuretics. If you give a diuretic, you have to assess the effect of the diuretic. The loop diuretics work for 6 hours. So there's no need to wait until the next morning to re-evaluate that patient. No, you have to re-evaluate the patient within hours after you gave the loop diuretic. And you can do that by 2 ways. The first way is to assess urinary sodium. You just take the first urine sample, send it to the lab, and you measure urinary sodium content. That should be at least 50 mg per liter. If you don't want to do that and you want to do it more difficult and measure urinary output, because that's not so easy to measure, that should be at least 100 cc's per hour. And you have to do that within the first 6 hours after you gave the loop diuretic. The reason why you have to assess that so quickly is because if your patient is not responding well, you have to change the therapy. So if you did not reach your goals, you have to double the loop diuretic after 6 hours. So if I gave 40 milligrams and I did not reach my threshold, then I'm going to give 80 milligrams 6 hours later. If you reach your threshold, you just repeat the same dose of loop diuretics every 12 hours. What do you do while you're giving that loop diuretic therapy? Well, you continue guideline-directed medical therapy. You don't stop the ACE, you don't stop the ARNI. You consider early use of MRAs if the patient was not on it yet. You still do salt and water restriction for acute heart failure, and you give IV potassium and magnesium if necessary. The reason why we emphasize so much on the urinary sodium content is that it's very important to get rid of sodium as fast as possible. This is a study we've done over 3 consecutive days of loop diuretic therapy. And on the left panel, you see the urinary output per milligram bumetanide. And that stays more or less the same, about 1.4 liter per milligram bumetanide. However, the quality of the urine is dramatically changing. Every day of consecutive loop diuretic therapy, you lower the urinary sodium content. So So that's why we have to be fast in the first 24 hours. What do you do after 24 hours? Well, you evaluate the 24-hour urinary output. If the patient is still congested and has more than 4 liters, you continue your current dose regimen. If the patient was not peeing enough, so less than 4 liters, again, you double the dose of the loop diuretic until you reach the 5 milligram bumetanide or 200 milligram of furosemide. There is no need, there's no value in giving more than 200 milligrams of furosemide bolus. You're not going to reach more. That's the moment where you have to combine with a different type of diuretic. The first type of diuretic that you can give is, for example, a thiazide. Thiazides are drugs that work very distal in the nephron. And just give me one second. So they work very distal in the nephron and they have a very poor diuretic effect, but they might counterbalance the distal hypertrophy that you see with chronic utilization of loop diuretics. You have to bear in mind, however, that thiazides are linked with an increased mortality and heart failure risk. So you should not be given thiazides on the long run. You can use them as a breakthrough drug, but once your patient is dry, you have to try to stop them again. The other drug that some of you are thinking is high-dose spironolactone. High-dose spironolactone, 100 milligrams, was tested versus low dose, but it did not lead to improved urinary output or to a more pronounced reduction of NT-proBNP. So spironolactone is very important, but a high dose is not going to give you more a diuretic effect in acute heart failure. And that's why we have to change our gears to another part of the kidney, and it is the proximal part. Like I alluded to previously, we absorb most of the sodium in the proximal parts of the kidney. So if you give a drug that works more proximal, that will boost the effect of loop diuretics. The oldest drug that we have is acetazolamide. You can give it 500 milligrams IV bolus on top of loop diuretics once a day. We tested it previously and it boosts loop diuretic effects. Together with HFA, we're doing a randomized clinical trial to actually assess if that also leads to an improved outcome. We hope to finish the trial within a year. The other agents, of course, that work proximal are the SGLT2 inhibitors. SGLT2 inhibitors block glucose uptake. They do not lead to an increased natriuresis, but they give osmotic diuresis. And this osmotic diuresis also leads to more effective decongestion. And the drugs are actually tested in several trials of acute heart failure as well. We're actually doing this study. It's called the ENACT study. And ENACT is actually testing the HFA algorithm that I just presented to you. And if you want to participate in this trial, just send me an email. We're looking for sites also in the Middle East. We have several sites in Europe and North and South America and even in India, but it would be neat if we have some sites in the Middle East as well that could participate in this very simple designed trial. And then the next point is the evaluation of kidney function. This is documented Heidi and I wrote together with HFA to give you an insight or to help you how you should look at kidney function throughout the heart failure trajectory. And this is the patient that Heidi was alluding to. Heidi's patient came in with acute heart failure and developed worsening renal function, meaning an increase in serum creatinine while you're trying to decongest that patient. So if you see an occurrence of worsening renal function, you have to think about it stepwise. First of all, of course, exclude a post-renal factor. If the patient has a problem in his urethra, maybe you have to place a Foley catheter. But if he doesn't have a post-renal factor, you have to look at that patient and to assess the diuretic response. If the diuretic response is well, so he's peeing out well, and you're giving loop diuretics and you see an increase in renal function, that is what we call pseudo-worsening renal function. There's no need to be alarmed. You just continue your decongestive therapy. The patient is responding well to the diuretic therapy, is still congested, and you just continue your diuretic therapy. However, if you see a poor diuretic response and you still have congestion, you escalate your diuretic therapy. But you also there have to assess if there is hyperperfusion. Congestion with hyperperfusion and worsening renal function is an alarm. However, like Dr. Feraz alluded to, that's pretty rare. Most of our patients do not have hyperperfusion, because if they have hyperperfusion, then they need an inotrope or they need a mechanical circulatory support. But that happens in less than 5% of our patient population. Most of the times they don't have hyperperfusion, and there you can just increase the diuretic intensity, and you might consider still IV vasodilators. Why? Because they actually work. This is a very simple algorithm. Just give me 1 second, please. This is a very simple design drawing of the Frank-Starling curve. And what you could see here is that a normal heart is preload dependent, meaning if you increase preload, stroke volume goes up. If you increase afterload, that does not really influence the stroke volume. If you give a vasodilator to a normal patient without heart failure, the blood pressure will drop because you decrease preload so much. However, if you have a patient with heart failure with a very dilated ventricle, those patients are more afterload dependent. And if you give a vasodilator to such patients, you move them from D to E, you decrease afterload, you increase stroke volume, and you also put them in a better point in their Frank-Starling curve. Therefore, stroke volume will be tremendously increased. That is why vasodilators still work in patients with acute heart failure who have dilated ventricles. This is probably one of the nicest studies ever been performed. It's a study with 25 patients published in the New England Journal of Medicine. And it's a study with nipride. Nitroprusside is an arterial vasodilator, and it's shown to be effective in patients with LV dysfunction, low cardiac output, and severe aortic stenosis, meaning that the systemic vascular resistance was not the culprit. Systemic vascular resistance is not the only thing which is determining afterload. Afterload is also determined by LV dilatation. The bigger the ventricle is, the higher the pressure, the higher the radius, and the lower the wall thickness is, the higher the afterload. And that is why drugs that work through afterload reduction in dilated ventricles, not in HFpEF, but in HFrEF patients who have decompensated heart failure, work really well. Hadi and I learned how to use nitroprusside. You can just give it through a continuous infusion. You just titrate it up to a mean arterial pressure of 60 just by the nursing staff, and you always see an improvement in hemodynamics. We've done this together, Hadi and I, when we were still in Cleveland, and when we compared nipride with no nipride in this really specific phenotype of decompensated HFrEF patients, you might end up with better prognosis. There are new drugs on the horizon, however. We have vericiguat. Vericiguat is an oral vasodilator drug, which seems to be beneficial in patients with heart failure up to BNPs of 8,000. There also has been the presentation of the omecamtiv study last week, which was not so beneficial as vericiguat, but still there's a lot of drugs being developed now that might help in acute heart failure as well. Other devices that might help us to relieve congestion, yes, there are, of course. We have ultrafiltration. We used to use ultrafiltration a lot, but nowadays we don't need it that much anymore because we're using that diuretic algorithm like I just showed you. The difference between diuretics and ultrafiltration is striking. Ultrafiltration removes isotonic solution, so meaning the same amount of sodium as you can find in the plasma, while urine is always hypotonic. The second device that you might think of in the future, because it's still investigational, is DSR. In DSR, we administer a low sodium infusate through a portacat catheter in the peritoneal cavity. We let it dwell there, and we let it basically attract more sodium, and then that water will be pumped through your bladder, and then you can just pee it out. So these are under investigation and are promising. Another device which may come to the market within a couple of years is this. It's called TRVD, and it's basically a pump that you can place in the renal veins that can actually lower down the renal venous pressure. So this is a catheter that we placed in the right renal vein, and you can see the pump flipping out, and then you turn the pump on. This is one of the animal experiments which we did in sheep, where we actually inflated a balloon in the vena cava inferior. And what you could see is, of course, an increase in venous pressure. And then we put the catheter on. The blue lines are in the treated, the red lines are in the untreated sheep. And what you could see is you lower down the renal venous pressure, and as soon as you do that, you see an increase in urinary output. But of course, this is still very preliminary. What to do on the long term? Well, we can try to better monitor congestion through this MEMS technology. I think most of you are familiar with it. MEMS is basically technology that you place in the pulmonic artery that can follow pressures ambulatory. Patients send me their pressure every day and we react to trends to pressures, and we try to change therapy before they have their onset of heart failure. It's not only Abbott who has this center. This is another company, Endotronics, and we were involved in the first in men study. It's a little bit, it's not better, it's similar technology, but it's easier for the patient to measure, because with CardioMEMS you still have to measure through a pillow, while in this device you can measure it through a handheld device which you can hold just in front of the sensor. We've done a study with SGLT2 and MEMS technology, where we actually looked at patients who had an increase in pressure assessed by their MEMS technology. We put them on an SGLT2 inhibitor, and all of these patients had a drop in their congestion. So again, more and more promising data for SGLT2 in acute heart failure. How to follow renal function during chronic heart failure, just to end. Well, you have to realize that once you reach the age of 50, you lose about 1 ml of GFR every year. If you have heart failure, that goes up to 2.5 mLs per year. And if you have heart failure plus diabetes, it goes up to 5 mLs per year. So you have to do your utmost best to stop that decline or to try to change that decline. So the GFR by itself is important, but it's also the drugs that you're taking into consideration the GFR that you're having. This is a graph where you see in the x-axis the GFR and in the y-axis the hazard ratio to die or to be hospitalized with heart failure. When you look at the arrows, you can have a low GFR with a low risk or a low GFR with a high risk, depending on the drugs that you're taking. Let me put it in a different phrasing. If I would have a GFR of 30 and I was taking an ARNI and an SGLT2, my prognosis is better than if I would have a GFR of 40 without these drugs. So is GFR important? Yes, extremely important. But are the drugs important that you're taking? Even more. So you have to combine both to assess risk. And we know that both ARNIs and SGLT2s can lower down the decline in GFR. They can lower down the risk that you would develop end-stage renal disease. So these are very important drugs to put your patients on. So to conclude, first of all, diuretic therapy, you have to start early and evaluate the effect as soon as you give the diuretic. You can do that either by measuring urinary sodium content or by measuring the urinary output. Reassess congestion and the ongoing need for diuretic therapy after 6 hours and change the therapy if needed. But chronic prevention comes through up-titration of neurohormonal blockers, treatment of comorbidities, and a multidisciplinary disease management strategy. Kidneys are very important. CKDs affects half of our patient population, is associated with a double risk of all-cause mortality. It's even stronger predictor than ejection fraction. But bear in mind that the misinterpretation of GFR changes often results in inappropriate discontinuation of decongestive therapy or inappropriate discontinuation of neurohormonal blocker therapy. I thank you for your attention, and of course, I'm more than willing to take any of your questions if you would have some. Hadi, I'm going to give it back to you.
Thank you, Wilfried.